So thank you very much. It's a pleasure and privilege for me to be here. So I'll be a little odd man out because I am traversing an area which is desert. Nobody goes there. COPD pH is a West paper basket diagnosis. Hardly people take interest on it. But it's a very, very important and quite common phenomenon in our practice. Can I have my slides? Well, for the interest of time, I'll move a little fast. And I'll answer some questions myself. And I hope my revered panel won't mind it. All right. COPD-associated, it starts with COPD-associated. Well, let me continue. COPD we find day in and day out. And pH is not uncommon in COPD. It can develop as a complication of COPD. Basically, to our mind, there are two classes of COPD. One is pH COPD, another is COPD pH, like ILD pH and pH ILD. It's same as that. In pH COPD, pH is a predominant. There is high pulmonary artery pressure, but the COPD is minimal. There is very low airflow obstruction. In COPD pH, it is reverse. The patient has got a severe COPD and mild to moderate pulmonary hypertension. But this is a very simplistic approach. If you get into this classification a little more, I'll show you. You may have many more things inside. The second is that it is not uncommon. We have seen in our practice roughly 30-35% of patients of COPD form the total bulk of our pH patients. We see all kinds of pH, not just COPD pH or ILD pH. Sometimes we find other groups of pH also coming to us. Could you find it? Yeah, thank you very much. Well, this is my disclosure. I am a grassroots pulmonologist. I should have mentioned. I neither practice in a corporate nor in a teaching hospital. So it's all solo journey, and this is what I have already said. And this is the first question I answered myself, that if you take COPD pH, then it could be unmixed COPD. It can be COPD mixed with group 2 pH or group 4 pH, or with the second group 3 pH. COPD ILD can coexist. And if you go for pH COPD, then it can be COPD with pH and a predominant vasculopathy with pH, which is called pulmonary vascular phenotype of pulmonary hypertension in COPD. So you can see it is a little complicated now. Okay. How frequent is pH? I have already answered. It's roughly 35%. Why should we bother about COPD pH? So I'm just skipping it very quickly. It is quite frequent. It worsens symptoms and exercise limitation. It causes functional jeopardy. It affects survival and makes it worse than PAH or PPH. It's been already discussed in the morning. So but the most important thing to my mind is there's no guideline to treat. Once you find somebody where you are helpless, you can't do anything, then you feel to do something for that patient. So that is the most important issue to me for getting into this business. Okay, sorry. Anyway, there are multiple Kaplan-Meier curves showing that the survival prospect is poor in COPD compared to, and it depends upon the PA pressure. I think it cannot hold very fast movement anyway. So this is, I couldn't check myself. It's a big registry of 2,067 patients where COPD or LDPH or lung disease pH actually took about 26%. And once we compare the survival, you can find that PAH versus LDPH, 1 year, 3 year, and 5 year survival, it is worse in LDPH. And one more important issue is that we are always thinking that ILD is the worst thing, not that. ILD COPD has got same 5 year survival rate. So it is equal as ILD for COPD. So how to identify pH? Here there are 3 steps. One is suspect, detect, and confirm. So may I ask Dr. Shubhro briefly to say how to suspect and how to go ahead with ECG and basic investigations, with the outline.
So in our day-to-day practice, to easily find out what is pH when we have to suspect pH is one is on the X-ray, if there is a pulmonary artery conus prominent, or on ECG there is a tall P waves, and on CT scan, if we see that the pulmonary artery diameter is more than 16 mm, then we should suspect a pH in COPD cases. So these are small little things which we usually do it in routine practice, and then we can always suspect that, along with the PFT where there is more of dyspnea, or the DLCO is less compared to the airflow obstruction.
Thank you very much. These are all discussed in the morning, so I'm not going into details. I want to go a little fast forward. There's one thing separately mentioned is DSAT max of 2-chair test. I hope I'll be able to discuss it a little. So going to the next slide, this is my patient. He is a 63-year-old ex-office employee, had COVID in 2021, is smoked for 40 years, 10 cigarettes a day, and history of pulmonary tuberculosis was there 25 years back, treated well. He has progressive shortness of breath, non-responsive to treatment, and actually that is accentuated for last 3 to 4 years, and presently is MMRC 3+. He was literally panting when he entered my chamber. SpO2 in room air after rest was 97%. And his CAT score was 18. So he was a sick patient. Any diagnosis? Or any idea? Anybody?
It's a COPD or post-TB obstructive airway disease.
Okay. So let me go a little farther. This is a chest X-ray. It also goes well with COPD, and you can have scars. You see the hilar pulled up, and scars bilateral in the upper zones. Plus, there are a lot of areas of hyperlucencies in the lung, some calcifications in the right upper lobe and other places. This is spirometry, which shows very severe airflow limitation. There's hardly any change. 0.712 to 0.72 is a change with bronchodilator been given. So there is poor bronchodilator response. So what to do with this patient? The patient has come with a lot of hope. He's an advanced COPD, and he's suffering a lot. He's MMRC 3+, and he has got a very poor quality of life with CAT score of 18. Sorry. It's playing with me. So my next step was to go for echocardiography. This has become a routine for me to see an echocardiography for all the patients who have got a very sick presentation, and those who have got a desaturation exertion. I'll come to that issue later on. So what I found, I'm just reading out the important issues. The patient had a normal TAPC, pulmonary artery pressure was 40 millimeter mercury, and LV filling pressure is less than 10 millimeter mercury. LV filling pressure is my poor, substitute of pulmonary capillary wedge pressure. If the LV filling pressure is more than 15, I tend to think that there is some left heart disease. So this is a routine in our clinic. So it is a COPD, possibly precapillary pH. But the pH is low, it's 40 millimeter. So it's a COPD pH. I have not yet found any comorbidity to it. It is playing with me. Actually, I'm not hurrying now. Something is wrong out there. Anyway. Huh? It starts from that previous one. So, which investigation did I miss at this stage? Any of the panelists, please.
We could have done the DLCO, sir.
Okay. So what do you expect from DLCO?
If we want to differentiate whether this is purely a COPD related dyspnea, or if the DLCO is less in this case, then we can, there is a suspicion for pH.
Yeah, so it's a suspicion of pH, and DLCO gives an idea. Actually, we published as DLCO, if we say DLCO distance, if it is more than 30, then there is a evidence of pH, actually, and the ratio already been discussed, FVC by DLCO yes. More than 1.60. So, yes, DLCO could have been helpful to suspect pH prima facie. Body plethysmography, any role in such patients?
Air trapping,
I don't think, and it is not accessible always, so I didn't discuss. Sir, you want to say anything?
No, I don't think so. Your
Thank you,
lung
sir.
function will tell you.
So cardiac MRI, not accessible to me. I just, CTPA, should I have done? And right heart catheterization, any comments?
Yes, definitely. If patient is coming with severe breathlessness, falling DLCO, you can ask if patient is having sudden onset of breathlessness or increase in breathlessness and you have ruled out acute exacerbation, we can look for underlying CTPA. So you can do CTPA.
So you are meaning it is unexplained disproportionate breathlessness for which you are going for a cardiac catheterization.
Yes.
Your echo has been done by an expert. He says only PA pressure is only 40 millimeter mercury. Well, let's see.
So I would say rule out comorbidities. Look
Yes.
for comorbidities. Look for other features. If you're thinking of CTPA, look at a D dimer. Look if there's any DVT.
Very good comment, sir. In this patient, I think D-dimer and NT-proBNP should have been done. We are coming to it. So I'm not going into all these questions I marked for my panelists. I will just ask, what should we look usually for in echocardiography for such patients?
So usually when you ask for 2D echo, you should write, please look for TR, PH, EF. Because again, echocardiography is a screening tool, not a diagnostic tool.
Absolutely.
And you should ask for, like, you don't measure the pressures actually, you are measuring the velocity. So TR velocity and then calculating the PSP, which is pulmonary systolic pressures. Then obviously EF of both right ventricle and left ventricle. Again, as you mentioned, TAPSE. TAPSE is very important to look at to whether your right heart is straining or right heart is failing.
These have been discussed.
These are the things we should look for.
Length and breadth.
Yes.
In the morning by Dr. Tala. Basically, it's as a pulmonologist, what I do, I always look at the inferior vena cava first. Sometimes I go myself and try to see if I can make it out. It's very easy. And second is that you look at your right side of the heart. Before that, I look at the HRCT chest very thoroughly. I'll show it later on. Okay. I'm just recapitulating this ECG business. Sensitivity is 55%, specificity is 70%. So ECG is not very worthwhile, but most of the time we find normal ECG and we miss the peak P wave or slightly bigger P wave. The chest X is also important. If you see the pulmonary artery at root diameter is wider, the cardiac size is enlarged, the right ventricle is enlarged, they can well be made up from chest X-ray. They are good indicators. And here you can see the retrosternal space is obliterated. That means there is right atrial enlargement, right ventricular enlargement, so right side enlargement of the heart. And there are multiple measurements which are different between PAH and normal. So these ratios were very important. In HRCT, I will show you two. This has been already shown. The other is this. If you see in multiple lobe, the pulmonary branch is dilated compared to the accompanying bronchi. Here you can see it's not the signet ring appearance, it's the reverse. The signet is bigger than the ring, and picture, if it's seen in multiple lobes, it has got 100% specificity. Here you can see the right atrium is enlarged because a little bit of dye has come out here. And you can see the right ventricle also. You can make out the septum and the D sign. So this patient has got severe pulmonary hypertension. Not this particular patient, but it's a different patient. Okay. So that's what I told, that CT picture has got a very high specificity. And these are other CTs. You can see how it looks, right ventricle is grossly enlarged, push the left ventricle smaller. And I don't know what has happened. It actually showed this reflux of the dye into the hepatic veins in severe PH. The dye was given in the superior vena cava. It has been refluxed into the hepatic veins. You just look at it, and it means very severe PH. Well, if you see the sensitivity and specificity, if you add clinical picture, ECG and chest X-ray, it is 90% and 80%. If you add HRCT to it, the specificity goes up to 100%. I have not added echocardiography because I couldn't find any study taking all together, but it's definitely more than 90% plus 100%. And the other criteria is DSAT max in 2CT. It will further increase. I'll discuss it. Okay, I'm not going into details. They have been discussed. Now, this is a question I think may be tickling in your mind. I also want to divulge this to you. This is a new test called two-chair test. This test is very simple. Here the patient sits on a chair, gets stabilized for 1 minute once the pulse rate and saturation is not changing much. And the patient gets up, goes to the other chair, which is 5 feet away, front to front, sits there and comes back. And so this is one movement. He does such 5 movements, and after that, we continue to measure the pulse rate and saturation for 2 minutes at every 10 seconds. Every 10 seconds for 2 minutes. Here you can find that the pulse rate was 90 initially, it went up to 105, 103, 100, 95, so on. Ultimately, it came down to 88. And the saturation, it actually was 95% at rest. It fell to 91%. It has been automatic. This is spontaneous movement of the slides. Anyway, I want to go back. Can I go back? I will say next slide. You do it from there. I think it will be better. Okay, next slide, please. Next slide. Yes. Oh, no. Next slide. Yeah. You can have 2 curves. One is the pulse rate, the blue one, and the red one is a saturation curve. You can see the saturation, it dropped, and then it gradually went up to reach the baseline. Next slide. Okay. So here you can find that the patient has got desaturation of 4%, from maximum saturation to minimum saturation, and that we named as desat max. And below we can see how it moves. Okay, next slide. This is what happens in COPD and normal and pulmonary hypertension. If a patient has got COPD, suppose normal people have got saturation between 97 and 98. If a patient has got COPD, if a patient has got COPD, the saturation is slightly lower, maybe 96%. But if that patient develops PH, it will be 94%. So PH adds to more desaturation. Next. So what we need, one slide back. Yeah. So this is how it looks. If it is COPD only, if we take the whole area under the curve for pulse rate and saturation, the lower one is below, black one is saturation, and the blue one is for pulse rate. You can see the difference in COPD alone and COPD with PH. Next.
So Partha, have you compared it with the 6-minute walk distance?
Sir, we have done it.
So how does it compare in terms of...
Sir, these 2 tests are different. This is a post-exercise recovery response. It has got a pretty good comparison as far the desaturation is concerned, but they give 2 different messages altogether.
Okay.
Next slide.
You think you should combine the 2?
We should. And then we thought that let us see how does it mean for a pulmonary hypertension. So by then we started doing right heart catheterization in our patients through research sanction, and we thought that we'll see that PVR more than 2 and PVR less than 2. For desat max, it was highly significant difference. If you go to the echocardiography, there's any difference. If you go to right heart catheterization, some parameters are showing that's high significant difference, but desat max it is matching something which we've determined through hemodynamic investigation as right heart catheterization. Next. Next slide. Next slide. Yeah, that's what I've told right now. Next slide. Yeah. And here, this is a very important slide. If you take a desat max of 3.5, I took it more than 3. Many of our patients at 4, 5 like that, then the specificity is high, the sensitivity is low. But if 4.5, the specificity is roughly 80%, sensitivity is 72%. So as the specificity is better, the sensitivity is low, as expected. Next. Next, please. And we look for the correlations. The other one, the correlation curve. It correlated best with the PVR, pulmonary vascular resistance. So desat max actually reflects. Next slide. It correlates with the pulmonary vascular resistance with a correlation coefficient of 0.56. So it has the best correlation with the vascular PVR. Next slide. And then we made a VIP plot. Actually, it actually is a kind of multivariate analysis that shows the factors that influence the PVR. And if you anyway, it's dancing, no issue. The DSAT max has the best correlation, and the DSAT max has the best position in the VIP plot, suggesting that it can indicate raised PVR. And then we looked for the odds ratio for the DSAT max. It is 19.7. So it was very high odds ratio. So once you have such a clinical parameter, which you can do easily, you can possibly identify the patients with precapillary pulmonary hypertension. And if you look at these patients' hemodynamic data, their pulmonary capillary wedge pressure is essentially high, roughly around 16. So most of the patients had concomitant group 2 pulmonary hypertension. So in our patients who are advanced COPD, group 2 pulmonary hypertension is a major factor to influence, plus they have got precapillary hypertension. So this is how, next slide, next. This is that odds ratio, 19.55, although the range is quite a bit, and this has been published only last month. Next, please. These are the other questions, role of pro-BNP and ABG in the work of pH. So I think these have been discussed quite extensively. For sake of time, I'm not asking my colleagues, can we make a diagnosis of pH without right heart catheterization? So I'm keeping these questions to all of you. And is it important to do right heart catheterization in COPD? And in which situation would you actually look for right heart catheterization? These are also discussed. So anyway, any comment from my revert?
Sir, if there is evidence of overt right heart failure, or there is evidence of a right ventricular strain pattern we are getting, or out of proportion edema and dyspnea if we are getting in COPD, irrespective of the lung finding, what we are getting on HRCT or X-ray findings. Excellent. So we can go for this.
Dr. Talat, this has been discussed. If you have a right ventricular free valve strain, which is quite significant, would you, if it's not significant, would you ask for a right heart catheter for suspected right heart function assessment?
So GLS is an upcoming parameter. Again, it can be very doer dependent and also dependent on the software. Outside of the pH world, we still are not sure whether RV-GLS is translating into clinical improvement. So I think it's still a little premature focusing only on RV-GLS. But yes, if you look at the entire echo, especially in the case you showed, sir, with normal, just mild pH, normal RV function, and if you look at the TAPSE and the PA pressure ratio, the RV-PA coupling is excellent. So in your case specifically, I would not necessarily advocate for a right heart catheterization.
Thank you very much. What we mean that we must be very judicious before going for a right heart catheterization. And there are other criteria to look at possible right heart failure or right heart maximum. Longitudinal strain, global longitudinal strain is a new parameter to see, which gives an idea about the right ventricular muscular function. Okay, next slide. Next slide. Yeah, next, say. So it's what we do, we follow a composite diagnostic criteria in our clinic. We have taken clinical chest X-ray, HRCT, and Doppler echocardiography together, and if one or more of the points from each criteria, each group is present, then we declare the patient has got likely pulmonary hypertension. Next. Okay, next, this has been answered. Next. So let us come back to our case. This 2CT I didn't mention at the first occasion. This patient had progressive shortness of breath, accentuated for last 3 to 4 years. And when we tested the 2CT, the saturation fell from 97 to 81. 97 to 81, so the DSAT max is 18%, very high DSAT max. Then I thought there should be something more because, you know, some experience plays a little role. Next slide. Next slide. This is what was, his desaturation is going down and then up again. Next slide. This is a chest X-ray. I looked at the X-ray. There are multiple areas of lucencies. I thought, could it be a case of pulmonary thromboembolism or a CTEPH? Next, please. So next. Okay, next. So he asked for a perfusion scan because at that point of time we didn't have availability of ventilation perfusion. The right lung is hardly been seen. The right lung is grossly underperfused. Next slide. Next. And there is a mild tracer uptake in the right lower lobe. Otherwise, right upper lobe all segments and lower lobe all segments, they have got a perfusion defect. Left upper lobe, apical and posterior. Apical, posterior, anterior segment has got perfusion defect. So there are multiple perfusion defects of very large size, the high probability of pulmonary hypertension. With that, the question is, the patient has got such a low PA pressure, 40 millimeter marker, I cannot explain. Next. Have you got any explanation? I expected the PA pressure should be much higher.
Yeah, I think this is unusual, not
Unusual.
not commonly seen. Yeah.
So we looked for HRCT. Sorry, because I couldn't get those plates. There's nothing to suggest from HRCT. I looked for the NT-proBNP, which was 700 something, not that high. And D-dimer was also borderline. So we put him on prophylactic anticoagulant. Next. And we diagnosed him as a COPD/TOPD with CTEF. And right heart catheterization showed the pulmonary capillary wedge pressure of 12 millimeter and the mean pulmonary pressure as 25 millimeter of mercury. Next. So the question is, when do we seek perfusion scan or perfusion or ventilation perfusion scan in a patient? So any of you can answer.
When you deciding like very pH specific therapy being considered, or when you want to give vasodilators, that before that you should go ahead and do this. I would not put him on, at least for vasodilators, I would try diuretics and anticoagulant.
Actually, regarding discussion of a COPD pH, nobody has clarified very clearly when to do for a perfusion scan, but we have seen the patients who have got a DSAT max more than 7, 8, 9, 10, they've got a high risk of a secondary etiology added to it. And I started looking at perfusion scan in those patients, and roughly 60 to 70% of these patients have got perfusion scan positive. So in another word, this two-chair test has helped me to screen patients for asking perfusion scan or ventilation perfusion scan.
So,
Next. Yes.
with 7th World Symposium guideline just been published, I think it says that in every patient where the suspicion of pulmonary hypertension is high, every patient should be subjected for the VQ scan.
So I think if you're looking at group 3, you're looking at group 4, then the important issue is that you have to have a very high index of suspicion, because this is the most commonly missed group as far as pulmonary arterial hypertension is concerned. And VQ scan is something which will pick up even emboli at a lower level, which may be missed on a CTPA. So it's something that you should do when you're looking at pulmonary arterial hypertension, which has not been explained. But
what was the CTPA? Sorry.
CTPA was done.
Yeah, CTPA was done. And CTPA, as we find most of the time, the report is normal. They showed up to 2nd division and 2nd or 3rd division of the pulmonary arteries. And I sent it to a cardiologist friend also, who is accustomed with doing balloon angioplasty. He said, with this CTPA report, I cannot go ahead. So the patient is now on riociguat, and he has improved a little. He's continuing with home oxygen, riociguat, and all possible treatment for COPD.
And anticoagulation.
Yes, an anticoagulant. So next. Okay. So what more should we know? This has been discussed. I'm not going for that. Okay. Next slide.
So I'm not sure you'll be able to do a thromboembolic if you're not able. If your CTPA doesn't show much of a clot, and it's very peripheral, you would probably land up giving riociguat and anticoagulants. Intervention would be difficult to do.
Absolutely, yes, sir.
So this is regarding the general principle of treatment of COPD and associated pH. If it is pH COPD, it's rare, has been discussed, mild airflow limitation, severe pH, treat pH, or refer to a pH treating doctor. So one of my friends said, why to a PH treating doctor? Because experience matters, and it's been found that these patients behave differently than COPD plus PH. So they are totally different phenotype of patients. And for COPD PH, these are common: severe airflow limitations, mild to moderate PH, treat COPD and comorbidities intensively, pulmonary rehab to all, oxygen therapy, and no pulmonary vasodilators. And regarding oxygen therapy, people used to feel that this is the answer. Actually not that. Because hypoxemia, though thought to be the cause of PH in COPD, is not true. It is a half-truth. So in these patients, if you have a baseline saturation of 89 to 92, 93%, these patients do not show any improvement or increment in their well-being or pulmonary artery, reduction in the pulmonary artery pressure and long-term follow-up. And if the resting pH is less than that, it is just useless. You can give it, but it is not going to change the outlook altogether. So next slide. Okay, the same story goes on. Sildenafil No by Anton von Nureberg, who is a big shot in our pulmonary hypertension. And next slide. Next slide. As you all know, guidelines also say no recommendation to treat COPD-PH. We are standing here. I am looking for how to find a way out to treat COPD-PH. I admit that I treat COPD-PH with vasodilators. I admit that I follow a protocol, and that's been given permission by DCGI and ICMR. ICMR give me a grant given. And I admit that till I do not know, still today I do not know which patient will improve and which not. So some patients, they improve, they make me happy, and some patients make me baffled why they haven't improved. So it's such a wonderful area. So many factors are there to influence the outcome. It's very difficult to say. A lot of things we do not know, a lot of things we have not yet approached yet. Thank you very much.